what we're doing?
Yeah, we'll just put that up.
No, you do. Yeah, you just introduce them.
Well, I know I'm going to.
Yeah, okay. I was just checking.
All right. Welcome back to another episode of First Responders and Coffee of an old school, new school edition.
I'm Jason Jolson. I'm a paramedic in Alberta.
And I'm KJ. I'm an EMR in Alberta.
So today we're going to talk about documentation, right? Writing PCRs. Some people struggle with them. Some people don't. Some people think they're really good at them, but they're not really good at them.
That's a common one.
That's a common one. So today we're going to go over 10 pitfalls to improve your PCR writing to actually, and I guess because it's a pitfall, we're actually looking at
common mistakes
and things to make things better to be aware of. So one of the first ones, let's talk about the first one is incomplete or missing information. So when we complete our PCR, we want to complete it entirely. We also want to make sure that if we're using an ePCR, we didn't just go through and checked off all the mandatories, but we forgot to add other things from our assessment and that kind of thing.
And don't forget, hit to hear your right buttons, your right things. But also, if something is not in, especially for ePCRs that are on tablets and have the touch button system, right? If it doesn't have it, you search it up and it doesn't come up as the thing, and go to the other and click the other and write in there.
Yeah, there's usually a narration place as well, right? To write your narration, you can do it in there. The other thing too is make sure you got all the patient's information. That's a huge one, all the demographics. And I mean, even most of the time, the idea is it's using for billing, but it also identifies the patient. So when they get to the hospital, they know who these people are and they know exactly who they are. There's no mistake on who they are.
For transfers, try to remember your MRNN and CSN.
Yeah, that's in Alberta.
That one's for Alberta specifically. That one's one that I have hiccups on sometimes. I've caught myself.
Number two, the big one, here's another one, clear language, right? So unclear language or using abbreviations. So we want to make sure that we're using clear language in our PCRs. The idea that everybody can understand what you're saying in your PCR. We can use, medical abbreviations. But again, like you said, some of these abbreviations can get mixed up. The other day, I just saw one for level of consciousness, and I didn't even recognize that's what it was. So make sure you're using the most common, maybe in your area. You might have a set standard of abbreviations to use. And what are the big ones that we shouldn't be using? Do you know?
Well, texting lingo.
Yeah, so basically texting shorthand, right? So we're not using LOL. You don't use those in there.
TTYL.
Yeah, TYL. There's a whole bunch. And I've actually seen PCRs almost fully written in a texting language. And the problem is, again, it's ambiguous. You don't know what it really is trying to tell you.
The other thing is going back to medical abbreviations. A lot of abbreviations can mean I think there's a CHF has two.
Well, the congestive heart failure is the one I know.
Yeah, that's the one I know. But I've seen CHF as something else. I forget what it was. And sometimes it's not clear. And it's the other thing with hospitals. So most hospitals have a shorthand, right? Like here in Alberta, the Royal Alex Hospital is RAH. The U of A is UAH. Misericordia is MCH.
Yeah, I think so.
And then, but you have Strathcona and Sturgeon, which both are S, but Sturgeon is SCH, and Strathcona is STCH. Sometimes it's easy to get those mixed up. So what I would suggest is in PCRs, if write the first time, write the full thing out. So Strathcona Community Hospital, and then in brackets next to it, put the shorthand of it, and then when you can use the shorthand later, because at least if it goes to court or somebody who's not part of the medical field reads it, they see that abbreviation's there, which means every time it's referenced, it's already been referenced once as the full name.
Exactly. This is a big one. Number three is lack of objectivity. So the idea that we talk about objectivity and subjectivity, and when we're writing PCRs, is the whole PCR should be objective. We're writing down what we've been told and what we've found. We're not assuming, right? We're not speculating what happened or why they took the medication and we think they were suicidal. Unless they told us they were suicidal, we shouldn't be including that in our PCR.
Really, it's almost like avoiding first person writing. You're not writing I think they believe this, or I saw this happen, or I believe, right? Use stuff right, motor vehicle accident on so-and-so, 2 vehicle collision. Not I think that this person drove into this vehicle.
Exactly. Another one too is subjectivity comes into dealing with people who are drunk drivers. If you show up and say, arrived on scene and I found a drunk driver, right, or this person was intoxicated, you know what? That is getting into the subjective area where objectively you would explain to them that you would use in your PCR that arrived on scene. There was beer cans in the bottom of the car. The patient stated that he was at a bar, drinking heavily. He had slurred speech, a taxic gait. And you can just explain that it's basically what you're doing is you're pointing out the behavior of the patient, not assuming what they were doing.
Not labeling them immediately.
Yeah. Another one too is you get heavy into your PCR. Depending on the acuity of your patient and the level of call you're working, you can get into stuff like you might fail to document changes or interventions. So it's very important that we need to do that, especially if we perform a treatment. We need to document the intervention and then what happened to it. A lot of times that we'll do an intervention and you won't see any follow-up throughout, basically in the treatment part of your PCR, about whether that you've given bolus like a liter of fluid. Did the blood pressure get better? Did it stay the same? So you can really have changed, unchanged, right? Improved, worsened. It's pretty simple.
If your patient doesn't, obviously, right, their condition doesn't change while they're with you, don't click the changed or improved or worsened buttons, right?
So for the most part, most of the PCRs we write now in Alberta, we are using a electronic PCR. A lot of it's basically you just tap and stuff. It's supposed to, just offshoot. It's supposed to increase efficiencies. I think it does in the end for collecting data. It increases the efficiencies for the min end of it. But when you are doing these PCR, it's like when you have a complicated call, a complex call, it does take a lot of work, right? The next one too is having inaccurate information or inconsistent documentation. So one of those is that make sure you're using proper spelling, right? Inconsistent or inaccurate. People can't, if you can spell, some words are so close together that you can't tell them apart, like whether it was supposed to be this word or that word. Another one too is that make sure that you're not contradicting yourself throughout your PCR. And if you were contradicting yourself, it probably was an intervention that you did that the person got better. Like there was a change, but you didn't document it.
Number 6, we're at insufficient detail. Not enough information, right? Not explaining what you've done enough, or not explaining what happened, right? If something weird happens on the call, make sure you explain that in full detail, right? Don't just leave stuff out.
Same thing when you're doing your patient assessment. You're going down to your on exam portion, right? You're starting out with a level of conscious. Make sure that you give good, clear descriptions. Again, this comes back to also, you notice these kind of run into one another, right? Like clear language. Same thing. We don't want to have misinterpretations of what we're talking about. So we need to have clear language of what we're doing. We can't have inefficient detail. Don't get halfway through the PCR, start, maybe you didn't finish a full sentence. And then too, like here we're talking about, might want to include like locations, being specific. If you're at a motor vehicle accident, if you're actually at a house where you might be going to court, you might even include the address that you responded to or where the people were more detailed in the room. If there's a lot of blood in the room and you're going to an assault and it might go to court, you might document that as well. Another one we can run into, number 7, is lack of clarity in medication administration. So we need to make sure that we document the time, right? The name of the drug, the dose of the drug, the route, and what our results were. So when we're going through that, we make sure that we keep all that in there so there's no ambiguity what was given. One of the things I do find when we're given drugs and filling out, especially when you're getting it complicated, if you're writing a complex code, or if you're doing a sedation to intubate, like an RSI, you need to keep track of those medications and you keep track of the time. Now, because we use EPCRs, let's just talk about that for a second. When we're writing our narrative, most EPCRs have an area to write a narrative. So when you're using a PCR, you might write a short narrative, maybe a few things on exam that are very pertinent. So if a doctor or a nurse picks up your PCR, they can read quickly and understand. You do not want to put times in your narrative in your EPCR.
Yeah.
Because you'll be time stamping them somewhere else, and then you're going to get into that.
I'm 2 minutes off.
Yeah, the inconsistency one that we just talked about, right?
The other one is for like I would say transfers is to getting like what obviously time, dose, and route what you given if you're on one of those transfers where you are going to be giving something, but also get in the information of what was given at the hospital right, because that will be big. They want to know when you get to that next site what they were given so they don't double up on drugs. Were they given their pain medication 2 hours ago? Were they given it just before you left? Which pain medications or general medications are up to date? Did they have their blood thinners? Did they have this?
No, and that's a great idea to make sure you have that, because I've done transfers out of the ER where we got to get them to another hospital really quickly, and we show up and they start asking you, what antibiotics have they ran on this patient already?
And if it's kind of difficult to get some of that information, so it's always good to get the paperwork, the MAR, the medication administration record, because at least that has like if they've been given a lot of medications, you can at least hand that over and go, these are all the medications, and they have their timestamps of when they were given, and then you can either, if you gave any, then you can give those across, or I didn't give any on my way there.
Yeah, exactly right. So it's the biggest thing is keeping track. Number 8, failure to include pertinent negatives. So sometimes we rule things in by ruling things out.
Yeah,
Make sense to you?
it does.
So if I'm dealing with a patient with chest pain, I want to rule in whether it's cardiac or musculoskeletal. So if I'm dealing with a chest pain patient that appears to be cardiac and I palpate his chest a lot and he has no increased pain or discomfort on that palpation, that would be a pertinent negative to include with the cardiac patient. So a lot of times, basically what we're doing is we're just trying to paint a really good picture of what's wrong with this patient. And again, that's objective, that's objective information, right? It's straightforward. It's what we're finding. You can also use your PQRS in that as well.
Like what's that board game? Guess Who?
Yeah.
Sometimes instead of guessing what the character has, you got to guess what they don't have to get closer.
Yeah, exactly, right? So basically you want to make sure you include your pertinent negatives. Now, just because somebody doesn't have it, it doesn't show up, it doesn't mean it's a pertinent negative.
Yeah, it doesn't mean it's immediately ruled out. We
just got to be real that, I don't know if you've gone through, I don't know if you guys did in school, but when you go through, I've seen somebody else's PCR that went through school, it was about 4 pages long. In the real world, you're given like that much space to get all your information into. We're in the digital age, you can type a lot, but then you also have a time factor, right? You have a certain amount of time you need to like get this information done.
Which is why it's good to have a template. If you can get a template, like on a Word doc or something, right, something easy, throw that up there. Google Docs. I know you use Google Docs. I used Word. It's easy. Click the button, then you can plug and play, put all your information in, and then it saves you a little bit of time so you can write more and keep your detailed PCR.
This is another one that comes to do with documentation, but it is the omission of your handover, right? Omissions are that when you're doing your handover to your nurse or the doctor, or if you got a big trauma and you have a whole trauma team standing there and you're about to give your information, even though this isn't really in your documentation where you write it down, but we're just being very clear that you got to make sure that you have all your ducks in a row when you're about to give that report. And you want to be able to give it concise, very chronological from start to finish, and you want to hit the highlights. We don't want to be including stuff that happened to this gentleman maybe 30 years ago. He stubbed his toe and broke it.
Again, pertinent information that's like right important to what the treatment he's going to need. The other thing is also, for transfers, I would say put in when you've given report and patient care has been handed over. That one's an important one, because then if something happens and you happen to still be attached to the call, but say you transferred care already and in your thing it says it was transferred to the nurse, and the last thing you saw was they moved to the thing, covers you. So.
Oh yeah, and that as well too, right? The other thing to look for is the idea that you want to include what your follow-up care. You also want to include some past medical history, right? Like if it's a short of breath, you want to make sure that you know that this person has years of CHF. Oh, and guess what? We're down to number 10, and it's just basically delayed or incomplete documentation. And I'm going to just really more talk about on the delayed PCR. The idea that most of us in our industry, we try to get the PCR done right away after the call. And that's probably one of the better times to do it.
It's most fresh.
Yeah, it's most fresh. You can go through it. The other thing you can do too is to help you with all of this is you can get your partner. I can have my PCR. Christian and I do a call. I hand my PCR to Christian. He can go through and make sure there's no gaps. The longer you wait to do the PCR, the more chance you have of forgetting something. Also, we got to remember the PCR is a legal documentation.
Yep.
And once you've signed that PCR and you dot the I's, cross the T's, and you, especially like EPCRs, you finalized it, that is now like evidence, right? That whatever happened on that call happened there. Everything else outside of that will be hearsay. And there is that thing, depending on how much stress you're under, depending how bad the call was. Like, say you've had, again, like I said, a very complex call. Sometimes you might want to take a few minutes after the call, take a few deep breaths, maybe grab a snack, and then sit down and really hunker in to write your information about the call, because sometimes you can lead into an area where you might actually miss stuff too.
Yeah, and the other thing is like, right, if something doesn't happen or you didn't check something, don't put it in that you checked it and just said there was nothing there. Right, that's kind of, I would say,
Well, it's negligence.
Incomplete, because you didn't actually do that. You just put that in there because you wanted to cover it. I would say that one was one of the big things.
Actually, that's an important one, is that
you didn't check
delayed or incomplete or whatever PCR, like it took you a while to do it, but make sure that you're not adding stuff to the PCR that didn't happen.
Yeah.
You have less chance. You can play the game that, and I've seen it. You say something to the, we checked their back and everything when they didn't find anything, and then they roll them in the hospital and now there's a bullet hole in the back.
Yeah.
Right. So really probably what happened on that call, they probably didn't roll and expose and check the back. If you put that in there, just say you did not get around to checking the back.
And I would say the other thing too is sometimes, and I know in like Stereo Land in school, they make you write, an 8-page PCR, because most of the time those calls that they're giving you are jam-packed. Sometimes you have calls that not a lot happens.
Yeah, well,
so don't be afraid to have, if your document doesn't have a whole narrative, doesn't have isn't a 2 pages, that's okay. Sometimes nothing happens, right? A lot of times on the transfers that I do under NAT, a patient ambulated into my stretcher, we load them into the vehicle, and we drove them to their thing. They ambulated out of my stretcher into their own bed, and that was the call, right? They could be quite healthy people, or they didn't even leave my stretcher. We went for an appointment, and then they got scanned, and we went back, and we didn't have to do any interventions. They had no changes.
Well, exactly. And the thing is that we just got to make sure that we're doing our documentation correctly, and to ensure that we do a complete, accurate documentation. Because really, when we talk about it, your documentation will reflect back on you.
Yep.
You do not want to go to court with a crappy PCR, or you don't want to have to go in front of, let's say there's a question from your medical director and they pull your PCR and they don't understand what the hell went on in that call, and now you're brought before them, and really you're a good practitioner and you did a really good call, but you just didn't take the time to do that PCR to dot the I's. And again, like Christian was saying, sometimes the PCR doesn't have to be that long. You can abbreviate things. This is one of the few times you don't need to write in full sentences. If you need to, as long as you're conveying the right information that people can understand it.
Right, understand that too. If you think about it in the way that if it was to go to court, some lawyer has to read it. Doesn't mean the lawyer knows what we talk, like knows our our jargon or lingo. Yeah. So make it clear and concise. You can obviously use your medical terms, right? Because that's what we all use, and that's clear to anybody else who would pick up your PCR. But don't put in stuff like that's that shorthanding stuff.
And don't. My other big tip is don't use big name words. If you regularly don't use big words, they're really complicated medical terminology that's like 27 letters long for one word. Don't add that to your PCR.
Don't worry to say it was his hands, or his fingers, or his feet.
Yeah,
right. He doesn't.
You can use the word broken instead of fractured, even. It's okay for that.
I would say I've seen some do it. I don't know what I've seen the fractured as what is a hashtag symbol.
Yeah.
Right. You can use that. You don't have to use big words.
Yeah, and you can use, like I said, again, you can abbreviate things. Just make sure that you're using the same abbreviations that would be used in the medical facilities you're going to and your service as well.
And if it is going to be different, write the full word out and then put it in brackets what the abbreviation is, and then use it later. Because if they ask you, well, this could have been this, you can go back and say, no, I wrote the full thing here, and in abbreviation, this was its abbreviation for this PCR. Right? Provide that information before.
All right. Those are the 10. That's all we got for you today.
And today was a little shorter one, but still.
We're still at 20 minutes. Well, maybe not full 20 minutes, but we're getting close to 20 minutes. We could keep talking about other things, random things.
I was going to say, don't forget, put questions we should do a question answer one and like and
Have you looked for questions?
Not yet.
Yeah, I haven't looked at all, so I don't know. Anyways, I'm Jason.
I'm KJ, and that was First Responders and Coffee. Have a good day.